We have about 10 minutes to take questions. I'm incredibly impressed by the level of knowledge in this panel, and I would urge you all to take advantage, both in asking questions now from the floor, for those of you who have questions, and in networking as the conference continues, because I think the two themes that have come across loud and clear from this panel of government at all levels is that there's both incredible knowledge and incredible commitment to this issue. So I'm really confident and encouraged hearing everyone speak that it's going to be really possible to make some progress today and to work together to share information. So let's begin. Anyone would like to ask a question of the panel, please. There are microphones in the aisles here. You can come to the microphone and introduce yourself. Address it to a particular panel member or to the panel generally. Do we have any questions? Yes.
Ricardo. I'm John Shaw from Next Wave up in Albany, and I was excited to hear that the CMMI awardees were brought together to think about coming up with a model program for asthma value-based purchasing. Where can we find out more about that?
Well, actually, if you go to our website, I think there should be a report posted there, and actually next couple of weeks there should be actually another report coming from the awardees.
Thank you. Yes.
My name is Jessica Irizarry. I'm from Puerto Rico. And my question is for Dr. Fish. You talk about the asthma home-based self-management projects. In Puerto Rico, we are currently implementing some chronic disease self-management programs. We're using the Stanford model, and we're using for diabetes, the University of Illinois one. I would like to know about this asthma home-based self-management project. Is it an evidence-based model, or is it one that you develop in the organization?
Well, thank you for the question. So the Performance Provider Systems had a toolkit, so there's a DISRIP toolkit on our New York State website, and from there they could select their various projects, and so they could choose the Stanford model or other evidence-based models, but they must be evidence-based for their home-based asthma management programs. And so it is left to the individual Performance Provider Systems in their application and their implementation plans as to which models they choose to follow, but they must be evidence-based.
Okay, so you're using a Stanford for asthma also, okay?
It can be used, yes.
Okay, thank you.
Please, go ahead.
Good morning. My name is Dr. Alan Dozer. I'm a pediatric asthma specialist and the director of the Children's Environmental Health Center of the Hudson Valley. So this past week, I was contacted by an administrator at a local community health clinic, and he's looking for funding, grant support for legal aid for his clients who are dealing with landlords, who are having environmental issues. And his idea, and I think it's a brilliant one, is that they need some lawyers in the clinic who could sit there and help them work out. I don't need to tell you, most of these are rentals, maybe sometimes undocumented. It's not that easy to say, oh, please stop the leak in your home. Any suggestions on how you could fund such a program?
I don't know what the funding mechanism would be outside of New York City, but I know in New York City there's a very large network of legal advocates who are in legal services and legal aid, as well as some other nonprofit organizations that get similar monies to represent low-income clients. They bring housing court cases all the time on behalf of clients. I'm not aware of ones that sit in clinics necessarily, but I do know that there are referral mechanisms from people who do operate clinics or asthma management programs. There's someone in the audience, I don't know if he's here yet, Ray Lopez, are you here? I think he's presenting later today. He is an example of someone who comes from an organization that works very closely with attorneys, so that's as much as I know here.
Does anyone else in the audience have any further information about legal services that might be available? Go ahead, Mark.
Hi, Mark Mataloni, EPA. Many of you are familiar with our Making a Visible Difference initiative. I'm the team lead for Newburgh, which is in the Hudson Valley. And one of the people that has been part of our coalition, first it was a Lead Safe Newburgh coalition, now it's grown into a larger health-related coalition. Her name is Lara Burkhoff, and she's with the Legal Services of the Hudson Valley, and I'm glad to connect you. But I think she's addressing the kinds of issues that you raised, you know, the legal aspects that create hurdles for residents that prevent them from getting good housing. So I'll be glad to follow up with you on that. But we have people like that in our coalition that are working towards that end.
Okay. Thank you, Mark. As a lawyer, I'm always so glad to hear when lawyers can actually be useful. Please go ahead.
I don't have a legal question. Dan Roush, I'm a pediatric hospitalist, the associate director at Elmhurst, and we've been extremely successful across the city in driving down the length of stay for asthma admissions and recognizing those frequent utilizers. The flip side of that is CMS and their 2-midnight rule is driving these kids, because we've driven the length of stay down to less than 2 days, to observation status. So it's challenging enough to recognize the kids, do the teaching, and invoke services for them. But now, because we've been so successful, we're going to get paid, I don't know, 50% for the same amount of work and churning these kids through, and that's just not a sustainable model for keeping up the same level of care. Do you have any suggestions or strategies to work on that?
A volunteer from the panel?
Well, my suggestion would be if we are successful in the DISRIP initiative, the entire goal is to try to keep people out of the hospital and the emergency rooms. So the stated goal is 25% reduction in avoidable ER utilization and hospitalizations. So as much as we can shift the asthma care to outpatient, good primary and preventive care, influenza vaccination rates for those with asthma, et cetera, we'll be more successful in trying to keep them out of those environments entirely. It is a challenge. What you say, you've been a victim of your own success, and congratulations for that. But I don't have another solution for that challenge other than maybe working with your performing provider systems in your area on it if they're doing an asthma project.
Well, I think that's one of the reasons why New York State and even CMS across the nation is trying to get to a more value-based payment structure that really, emphasize the fact that providers are actually, doing us a favor by reducing, utilization and actually saving not just New York State, but federal government money in turn. So I think at CMS we're definitely looking at that, and there are proposals that New York has brought in front of us, to try to, gear their system toward a value-based based system that also incorporates Medicare into that. So there's things that New York State in general has been working on with us.
Along those lines, it is stated in the value-based payment roadmap for New York State that 80 to 90% of the managed care organization payments by the end of year 5 need to be at a level 1 or higher value-based purchasing or tiering, and so that means at least some level of shared savings, if not shared savings and shared risk, or even a fully capitated per member per month all-in model.
Go ahead, please.
Hi, my name's Deborah Nagan. I'm the director of the Health Department's, New York City Health Department's Healthy Homes program. So I had one comment on the issue of the sort of tenant harassment. One thing that might be something to look up that folks upstate have been using is something called the Spiegel Act. And if they, New York State Health Department actually has brought together through our primary prevention program more information. I think that maybe the Rochester, Buffalo folks have used the Spiegel Act. So that's something to look at, and if you needed more information about who to talk to, definitely not the expert on it, but I think it's been used as a way, particularly if you're getting public funding for housing, as a way to address discrimination issues for housing. I had one question, hopefully it's not too much in the weeds for Dr. Fish. I saw in your presentation that you mentioned the Healthy Neighborhoods program, and that New York City has a Healthy Neighborhoods grant, and the wondering is, and these are grants that go to health departments across the state from the State Health Department, is there some specific way that you're thinking moving forward relative to DISRIP to work with Healthy Neighborhoods? Has that been discussed?
Well, I think the way that we envision is through the performing provider systems themselves. We're encouraging them to work with all the organizations, community-based or government-based, in their region. So those areas that undertook an asthma-related project should be working with the Healthy Neighborhoods programs in their regions to synergize their efforts.
Please.
Hi, my name is Jonathan Cohen. I'm with the Department of Energy in Washington. I co-lead a program on energy efficiency and health and run a national network concerning residential energy efficiency. And so in hearing the panelists talk about home interventions, in particular cases where it would involve doing work in a home to deal with the cracks and the indoor air pollution, the mold and the like, that would require people to do that work, which tends to be more the area that I work on. And in this new initiative I'm working on, I'm interested to find where those connection points can be with what I've been hearing, and I'd be curious if you could connect the dots for me a little bit more about how the kinds of programs that I work with across the country could connect with the kinds of programs that you work on to be able to get that work done in the home.
So here in New York City, I would say that we're really at a kind of pilot and a research phase for similar efforts. There are many programs across the city that do work in the homes attached to community advocacy organizations, primary care clinics, some of them you'll hear from later today. In our work, we see the role of the health department as one where we can play the kind of broker ground. So a referral from a medical care provider or a person with asthma who desperately needs services for pest control. Once we identify whether there's a payment system for it, whether we support it directly out of health department funds or in this research project we're involved in, we have funding from the Robin Hood Foundation to do this work. We basically contact the family. We contract with a vetted, high-quality pest control service provider, and then they do the work. So we think that that's an appropriate role for a reasonably resourced local health department. But they don't need to be the only ones. I mean, we're working with a couple of large managed care organizations, payers, and one of them in particular is already beginning to contract directly with, again, these high-quality home service providers to do the work. So they see it as sort of embedded in their own incentive system to basically play the purchaser role for those services.
Well, let's thank the panelists again, and I encourage you all to continue to talk during the break.